Good morning, everybody, and it is a pleasure to present this case that we did in our center a few weeks ago. So I'll just get started on the case. So the medical history, this is a 75-year-old male with a history of rheumatic heart disease. This patient had a double valve replacement, aortic and mitral, in 2016. He's also known to have diabetes, hypertension, atrial fibrillation, and he was diagnosed also with coronary artery disease on the basis of cardiac cath recently. He complains of worsening shortness of breath, NYHA class 3 to 4 over the last 6 months, which required a recurrent hospital admission due to decompensated heart failure and volume overload. This is his echo. As you can see here, he has 2 bioprostheses in the aortic and mitral position with severe AI, severe AS and mild AI. The mean pressure gradient is 72 across the aortic valve. His left ventricular ejection fraction is 55%. Mitral valve showed evidence of severe MS as well, degenerated valve with severe MR, and he has moderate to severe tricuspid regurgitation. When we did a multidisciplinary discussion about him, it was believed that the mechanism of the valve failure was degenerative wear and tear of the valve. It's almost 9 years old. These are the CT analysis. The level of the annulus, the average diameter is 19 millimeters, and the perimeter here is the area is 281, and the perimeter is around 60. And the SOV diameter is 28 on average. These are the coronary height. In the left coronary, it is 9 millimeters. In the right coronary is 14, and the STJ is around 18 to 19 between the right and left coronary cusp. And the VTC distance for the right coronary is 3.4 millimeters, and for the left coronary is 5.1 millimeters. So his vascular access was unremarkable and good for potential transcatheter approach. When we did a multidisciplinary team discussion about this patient, the ST score was quite high for operative mortality, which almost around 20%.
Okay, so maybe we'll stop here and get a panel consensus. I want to start by asking Dr. Mohammed Al-Banna. So this is a patient who had a small surgical bioprosthesis implanted 9 years ago, I guess. We're quite troubled with small annulus and small bioprosthesis, and we always wish to have larger valves to do a valve-in-valve procedure for. One potential solution is root enlargement. So my question to Dr. Mohammed, how often in your practice do you do root enlargements for those patients who are the potential candidates for a root enlargement surgery?
I have to admit, during my training, and I trained in a high-volume center, I would say I saw a root enlargement once in 6 years. However, as time went by and as we are now hammered with the lifelong management of aortic stenosis and valve disease, with the development and introduction of TAV, as well as this, you might think that this is funny, the presence of YouTube. Many surgeons now publish their procedures online, and hence we are, as surgeons, able to see procedures over and over again, done through different hands and at different centers, and hence we're encouraged ourselves to perform root enlargements more and more. I could tell you that in our center, we do not stock 19 valves on the shelf. We have 21 valves in small numbers just in case of an emergency, and our routine valve size is 23 to 25. This in hope of reducing PPM, patient prosthesis mismatch, and providing a let's say, a fertile environment for a later valve or TAV and SAV. One last thing is the development of a new root enlargement technique that made the root enlargement slightly more accessible to the surgeons.
Perfect. Maybe I'll ask Dr. Bedr, with regards to TAVI in a native AS, we don't routinely pre-dilate or post-dilate those valves. Would you have a lower threshold to pre-dilate or post-dilate in a valve-in-valve procedure? Sorry, Dr. Faisal Goofy.
It depends, I think, of the mechanism of the failure. This is a small valve, so you might even bring to the discussion whether you want to fracture this valve or not. But in general, for a regurgitant valve, we do not usually pre-dilate. For cyanotic valve, we pre-dilate. Most of the time, again, it depends on the type of valve you're going to use, self-expanding versus balloon expandable. If I'm using a self-expandable, I tend also to pre-dilate irrespective of the mechanism. I think probably Dr. Nabeel was going to show us what is the type of the valve and calculation. I didn't find for AI specifically that dilatation is very helpful, especially with a balloon expandable valve.
So I believe this is a 21 millimeter surgical bioprosthesis with an internal true diameter of 19, so very small diameter. Question to Dr. Abdurrahman. You know, the idea of valve cracking has been brought up today for this patient. Would you consider a bioprosthetic valve fracture for this guy? And if the answer is yes, would you do it before or after valve-in-valve TAVI?
Thank you for the question. It's very important to, if you decide to fracture the valve, you look for the parameters which support the fracturing, because the fracture, your aim of the fracture is to expand to accommodate larger size. So you have to go back to the measurements and see how is the sinuses, how is the sinotubular junction, because you need the area to accommodate the fractured valve and to expand it, and in the expense of some risk. And then add to that the risk of embolizations and the stroke risk and the fragmenting the debris further. So are you going to use the protection device? Though the evidence is not, until now, is not strong in favor of this, but at least in selected cases it may work.
Lastly, Dr. Bedr, our imaging expert, this patient has a left main height of 9 millimeter, which is kind of borderline for a valve-in-valve procedure. Are you worried about coronary obstruction in this case, and why?
9 millimeter is what? Sorry, again?
The left main height is 9 millimeter.
VTC is 5.
Yeah.
VTC is wide, I guess.
So I think the best way is if we can go through the slides just to show you how we approach these cases. So you can see this is the valve-in-valve. I'm sure all of you are aware about this app. So this will help you choose the valve based on that you know exactly what was the surgical valve from the beginning. So if you go to the next slide. So if you know the valve, you will choose if it's stentless or sutureless, and then you choose the exact valve type and size, and then this will give you a guide on what transcatheter valve you're going to implant based on the recommendation of this app. So for example, in this is not the same case, but this is a separate case where you can choose Magna, the stent size is 20, and then it will give you, for example, all of these self-expandable or balloon expandable valves and their sizes that they recommend to do on these cases. So how do we choose, I mean, like how to assess for the coronary risk? If you can go to the next slide, please. So now you chose your size and you assessed the size, the typical size you should do for this case. Next slide, please. So now, if it's a stentless valve from the beginning, you don't really need to assess the VTC that Dr. Nabeel showed, because there is no stent extension above or below the coronary height like here. So basically, in these cases, you should just assess the height, which is similar to any native aortic annulus or TAVI case. So in these cases, just assess the heights, and if the heights usually is more than 9 millimeter, then you're okay to go in most cases. Some people say 12, but I think from what I understood is a lot of you is taking like more than 9 millimeters is good enough cutoff. So how about if it's stented? So if it's stented, if your coronary, if your surgical post, which is the top of the stented valve, is reaching above the level of the coronary ostium origin, then at this time, like in Dr. Nabeel's case, you really need to assess the VTC, which was the valve to aortic or the valve to coronary distance, and see if it's more than 4 millimeter or not. If it's more than 4 millimeter, you're good to go in most cases. If it's 2 to 3, it's kind of borderline. If it's less than 2, then there is a really high risk of coronary obstruction. If the stent post from the beginning is below the level of the coronary origins, then you don't have to do anything. You can just continue without having any worrisome or risk for coronary obstruction in these cases.
So back to you, Dr. Nabeel. The consensus is that we're not really too worried about coronary obstruction because the VTC is wide, although the stent frame of the surgical valve extends beyond the left main ostium. And show us what we did.
Okay, so the multidisciplinary team approach, we decided to go for a valve-in-valve TAVR first, then followed by TMVR at a different occasion. So as Dr. Badr mentioned, for this patient, the issue were low coronaries for the left coronary and the narrow VTC and the STJ, potential STJ obstruction. So the surgical valve that was implanted in this patient was Magna, CE Magna, is 3000, and the size was 21. And as you see here, the true internal diameter is 19. Okay, and by plugging these numbers into this app, it will give you all the options as you see here in the middle panel. And it also can give you some simulation of how the valve would look like. So we decided to go, because of the VTC was spacious, we decided to go for a valve fracture. And we decided to go for a balloon expandable MyVal valve. So as you see here, this is just to show you a simulation of if you use a short versus long frame valve inside that surgical valve, and that's why we decided to go for a short frame valve. These are the criteria that we use to consider balloon expandable versus self-expanding regarding this patient, the small STJ ascending aorta, as well as the short distance to coronary ostium to the frame were in favor of balloon expandable. So we used a true balloon, size 22, and we fractured the valve, the surgical valve, and then we plan to implant our valve a little bit deep just to avoid that 9 millimeter left coronary ostium. And this was the final result. Left coronary was okay, and the right coronary was also okay. And this is a post-procedure echo, which showed trace AI, and the mean gradient across the aortic valve was 6.8 millimeter, and the mean gradient across the mitral valve was 10, and the patient will be scheduled for a TMVR soon. And this is a post-TAV CT that we did also to plan our TMVR in the future. And as you see here, both coronaries are okay. So in conclusion, confirming the type and the size of the surgical bioprosthesis is essential. Stented, preferred marker for the position versus stentless. Is it a fracturable valve or not? And then we individualize our plan using CT to determine the true internal diameter and consider the VTC and valve to STJ distance and the coronary height. And with that, I conclude. Thank you.
Nicely done, Dr. Nabeel. So what you use is a balloon expandable valve, although some people may argue that they want to use a self-expanding valve given it's a small annulus. But I think you did it really nicely that, you did PVF, make sure that the valve is cracked, well expanded. I would be really interested to look at the valve diameters on post-TAV CT to see if it's really 21.5 or not. So well done. Thank you so much.
Yeah.